Raphael, can you hear us? Because I can't hear you.
Can you hear me?
Yes, now I can.
Okay, sorry. So, hi everyone, my name is Raphael. I will be presenting the afternoon report today. Oh, it's not
I
working.
don't see you anymore for some reason.
Oh, it's not on my camera?
Your camera might be off, but we see your screen at least.
Okay.
Now we see you. Perfect.
Okay. So the chief complaint of our patient is shortness of breath for 1 week. We have a 67-year-old male with a past medical history of moderate persistent asthma, insulin-dependent type 2 diabetes, well-controlled hypertension, prostate cancer, obesity, and a recent diagnosis of esophageal adenocarcinoma, presenting with progressive worsening shortness of breath and poor oral intake for 1 week. He was also complaining of nausea and no bloody, non-bilious emesis for 1 week. It was usually 1 to 3 times per day, not associated with food. His dyspnea was even for daily activities. He was denying orthopnea, and he never had these symptoms before. He denied current or previous episodes of chest pain, palpitations, dizziness, fever, cough, recent infections, abdominal pain, diarrhea. He was not taking his insulin consistently for 1 week, as he was having some poor oral intake. He was concerned of hypoglycemia symptoms. And he was vaccinated against COVID and influenza and no recent travels. So the past medical history: hypertension, asthma. He was never intubated or hospitalized for asthma exacerbation. He has insulin-dependent type 2 diabetes, obesity, prostate cancer, and recent diagnosis of esophageal adenocarcinoma. His past surgical history is remarkable for brachytherapy for prostate cancer in 2017. His current medications are amlodipine and benazepril for hypertension, albuterol 4 times per day, fluticasone with salmeterol, BID, insulin, Basaglar, 16 units at bedtime, metformin, 1000 BID, and pantoprazole. And he denied any allergies. His family history is remarkable for his mother with heart disease. He doesn't remember exactly which kind of condition, and Alzheimer's disease. And his brother has also type 2 diabetes. He lives with his wife in his own apartment with access to an elevator. He ambulates with a cane and requires some assistance from his wife for daily activities. He smoked for 20 years, stopped 20 years ago. He used to smoke 1 pack per week, and he denied drinking alcohol or using any illicit drugs. For review of systems, it was positive for fatigue, decreased oral intake, and weight loss, 35 pounds in 3 months. Positive for dyspnea, nausea, and vomiting. He was also having polyuria and back pain. Otherwise, was everything negative. Should I go through the physical examination?
Yes, so we can pause right now if you want for questions related to the history. If you want to go back to the HPI as well, if anyone has any particular questions. Okay, I'll ask the first question. So in social history, why was the patient not taking the insulin consistently for 1 week?
Sorry, say it again.
Why was the patient not taking the insulin consistently for that week? Like, what was the reason?
Okay, he was having poor oral intake, so he was concerned of hypoglycemic symptoms. So he decided to not use.
Okay. We have a question in the chat. Bailey is asking any specific time or of the day for nausea, vomiting, or continuous?
Oh, no, no specific time.
Someone else is asking if the patient already started treatment for esophageal carcinoma.
No, not yet. He found out about the esophageal carcinoma a month before the presentation to the hospital.
Omar is asking if there was any dysphagia, probably related to opioid intake.
No dysphagia.
Joe is asking if he checked his sugars regularly.
No, he didn't have a glucometer, so he didn't check at home.
Nadim is asking if there were any infectious symptoms such as fever, chills, cough.
No, and no cough, no fevers, only shortness of breath.
Sarah is wondering about the presentation that led to the cancer or esophageal cancer diagnosis.
He was having, oh, sorry. Oh.
Yeah, if it was similar to today's presentation, Sarah is wondering.
No, it was not similar to today's presentation. He was having some abdominal pain. He went to the ED. They did a CT, abdominal and pelvis, and then they found out about the mass in the distal esophagus.
Mm-hmm. And Nadim is wondering about melena.
No melena.
Okay. I think we can go to the physical examination slide.
Okay. So for his physical examination, when he first came in, he was tachycardic to 120s. He was in mild respiratory distress. His respiratory rate was at 22, but he was saturating 95% on room air. It was also remarkable for dry mucous membranes and crackles in the lower base. His cardiovascular examination was unremarkable. His abdomen was soft, no tender, and he didn't have any JVD and no lower extremity edema.
Okay. Sorry, any questions about the physical? Anything else someone was wondering? And Emily was wondering if he had an endoscopy before as well.
Yeah, also after the CT abdomen and pelvis, they did an endoscopy. Then they biopsied the mass on the distal esophagus, and they found out about the adenocarcinoma.
Okay, no questions about further physical exam findings? Okay, I think we can, Nadim is asking pain in the legs or redness.
No pain, no redness.
What do you ask about that, Nadim?
Just because he's a cancer patient, so it's a hypercoagulable state. I know that there's no edema, but like just signs of DVT, something to explain like a PE why he's having shortness of breath. He's also tachycardic as well.
Exactly. So he's tachycardic, he's presenting with shortness of breath, and he has a history of malignancy. So that definitely puts him at a higher risk. Granted, like esophageal is not as related to other like tumors such as pancreas or stomach, but it is definitely something that'd be crossing your mind with a clinical presentation and the vitals. So does anyone want to go ahead and take a stab at the problem representation? And Rafa, if you could just go back again to the HBI just to help them out a little bit. Does anyone want to give it a shot? If not, then
I can try.
Perfect. Go ahead, Richard.
So this is a 67-year-old male with a history of asthma, type 2 diabetes, hypertension, prostate cancer, obesity, with a recent diagnosis of esophageal cancer, who presented with shortness of breath, not eating for 1 week. So he's also endorsed nausea, non-bloody emesis, and he's not eating any food. He doesn't have any orthopnea. On vitals, he's tachycardic, blood pressure is normal. He has a slight low, like it's not a fever, but a little elevated temp, and he's a little tachypnic. On exam also, he had dry mucous membranes and he has crackles on the lower bases. So like from a differential standpoint, I think PE comes to question given the tachycardia and his recent cancer diagnosis. So that's, I would say, my first differential. Second differential would be like probably DKA. And third differential could possibly be like a COPD exacerbation given his smoking history.
Okay, so you took a little bit of an extra step there with the differential, but I appreciate your ambition and definitely reasonable examples. Rafa, if you could show us your problem representation.
Yeah, so it's pretty much the same 67-year-old male with a past medical history of hypertension, asthma, diabetes type 2, obesity, prostate cancer, and recent diagnosis of esophageal adenocarcinoma, who presented with progressive worsening dyspnea associated with poor intake, polyuria, non-bloody emesis for 1 week, not using insulin for 1 week as well. Also noticed to be tachycardic with increased work of breathing and crackles on physical examination.
So can I ask, I always like to ask how someone came to the ER. Did he come from home himself? Was he sent
Yeah.
in from his doctor's office, or did he call EMS?
He came from home.
Okay.
Yeah,
Does that
one
tell you
thing-
anything? And for me, it always tells you the severity, right? If someone calls the ambulance from the house, you know, or they're found down at home and someone calls in, or they just decide, look, I can't deal with this anymore. It's time for me to go to the hospital instead of going to my doctor's office. It just tells you a little bit about severity to myself. May or may not be helpful, but
Yeah, I'll just say, you know, when we do these problem representations, and this is true also when we're presenting a new case on the wards, it's very easy to fall into the trap of rattling off a past medical history, you know, like a list of past medical history. What's more challenging, and I think should include the exercise of a problem representation, is the pertinent history, right? So I would have said this is a 67-year-old with a recent diagnosis of esophageal cancer, which hasn't yet been treated. I need to know that part, right? Have they had radiation? Have they had chemo? You know, what's going on with that cancer? How well controlled is their diabetes? Have you looked up a recent A1C? Is it insulin dependent diabetes? You know, I don't know how relevant the hypertension or obesity or prostate cancer is to this case. I mean, fine, I could be wrong, you know, 40 minutes into the case, but you have to sort of put your money down where it belongs. Like, you know, try to come to some kind of an estimate or a guess of what you're working towards.
What I was going to say in terms of that is that, to me, you know, when we're going through a case and we're presenting all the different aspects of the patient, when I go to past medical history, I think that's when it's relevant not to repeat all these diagnoses, but to give more specific information. You know, diabetes, it's not the same to have been diabetic for 1 year or for 20 years. You know, for each one of these diagnoses. In the case of the esophageal cancer, of course, we wanted to know, you know, what did they actually see besides the mass and the CAT scan? Was there any lung infiltration or not, given the current presentation? So, you know, my feedback is, in the past medical history, always include, you know, more information about those chronic conditions that are relevant to the case. And then here, in the problem representation, I think it's better to use categories rather than repeating. So instead of 67, I would say elderly male. Instead of 1 week, I would say acute. So I think it's better to put things into categories because our brain actually responds to those words that we use. Sometimes 67 doesn't trigger the same list of diagnoses than elderly. And then when we're talking about differentials, I know I'm going a step forward because we haven't got there yet, but most of the things that have been mentioned don't account for the crackles on the physical exam. And maybe that's why I would consider including hypertension in this summary, just because we don't know, there are crackles. And, you know, PE shouldn't give you crackles. I mean, we have to think, why does this patient have crackles?
Thank you so much. Yeah, definitely, it's super helpful. And personally, when I do this, I find it helpful to, like, when you start talking about a problem representation, it's kind of like something that you would tell when you're handing off a patient, and usually like the first statement when you're doing it on the rounds. And sometimes it's like, even after hearing like the physical and everything, instead of going back to the history and then drafting it, it's like first like mention all the things that stuck with you from the case after hearing it, like medically, what was relevant, and then you can like expand on that as well. But yeah, definitely the crackles, it's a great point, Dr. Frigolini, and I think that's probably why for you it was important that no JVD and no lower extremity edema, right, Raphael? I saw that you underlined it as well. So definitely, like, we need to start thinking about piecing the things together and making sense of things.
I also would have included in there that his saturation was normal. right? Because I think that makes a difference. Here's someone who's got an increased work of breathing, he's tachycardic, but his SAT is normal. So maybe it isn't so much the lung and maybe it's more cardiac, with some people are already suggesting.
Perfect. Now, I guess if we start talking about the differential, it seems like Nadim had also mentioned PE. I think Richard had mentioned also DKA. I think Raphael, from his example, he was thinking a little bit of CHF despite no lower extremity edema, JVD for the crackles. I remember Richard mentioned COPD for the smoking history. I would say the smoking history, it seems like it was 1 pack a week, like 20 years ago, right? I would say it's definitely like on the lower end. And like, I'm not sure if that's how it would be presenting, and especially like normal saturation, like Dr. Ray said, but something to consider. With a history of asthma, does anyone think it's asthma? Like as a cause of shortness of breath? Yes, no. Raj, I see saying pericardial effusion as well. And Lenise, aspiration pneumonia. Great. So that's also what I wanted to include. So you have someone with a relatively relatively immunosuppressed, right, with a recent diagnosis of cancer. He has diabetes. You have the patient has tachycardia. The patient has elevated respiratory rate, shortness of breath, and like an esophageal mass. We're concerned about aspiration as well. I think an infection at least should definitely be on the differential, right? If this patient like meets risk criteria just from the vitals that we have with the tachycardia and the respiratory rate. And I think that's also why Nadim was asking about infectious symptoms as well. Cheryl is saying, I would think maybe DKA high on differential, possibly related with community-acquired pneumonia. Okay, and anything in favor of or against DKA, anything that we saw in like the physical or anything supporting DKA besides the history and non-compliance with the insulin? What would we want to check?
Oh.
Sorry, I know Nadim, I interrupted you, I think.
Oh no, I was saying I don't know if the tachypnea would maybe also be like consistent with the DKA. I don't know if they would see like a respiratory like compensation or something.
Yeah, so you can definitely present with elevated respiratory rate, definitely as compensation for acidemia. But yes, Richard, the dry mucous membranes. So DKA is a state where like they're normally volume depleted, especially if you're considering, you know, crackles. Like if Raphael was thinking like, oh, could it be CHF? It seems like here we have dry mucous membranes, and it seems like from your exam, Raphael, it seems like he was a little bit volume depleted, right?
Yeah, exactly.
So yes, if we could name like, or if someone wants to name their top 3 differentials right now, like if you could say are like higher, lower. I would say definitely like the ones that worry me is like, okay, aspiration pneumonia, Sonal again. Sonal is placing it as number 1. I would say definitely like infection number 1. It seems like he didn't have as much esophageal symptoms, but even if it was like vomiting, you can have also like aspiration pneumonia from vomiting, and it seems like he's been vomiting for about a week. COVID, I would say possibly like less likely with the presentation, but maybe I would say like aspiration pneumonia, definitely something we want to rule out, or like, sorry, infection, possibly due to pneumonia, DKA, and definitely something that I would want to at least see initial labs or see if there's another reason for this would be PE, unless I find something in the labs that makes me think it's very unlikely. That's I would say a never misdiagnosis that you want to gloss over. Now, if we're talking about like the labs and initial imaging that we would order, what would you guys want to get and why? Labs and imaging, of course, I'm talking about.
Really chest X-ray.
Okay, chest X-ray, I think that's definitely reasonable. You know, if someone presenting with shortness of breath and you're worried about infection, and we're talking about possible aspiration, definitely. Venus said CBC, BNP, ketones. And it seems like many are saying Galit is also adding BNP, trope, and UA. So anyone want to start? So Venus, why would you want to get the CBC?
So I would like to get CBC in order to see the WBC count, because one of the differentials which I'm keeping is the aspiration pneumonia secondary to, vomiting, which he was having from 1 week. So definitely that would be elevated. And BMP, I'm hoping, just considering that could be elevated. And then BMP, see the kidney function, and then VBG as well, to see the anion gap for sure, and serum ketones, just to make the diagnosis of DKA, to rule out DKA or rule in DKA.
Okay, I think that's great. And Galit, why did you add the UA as well?
Part of the infectious workup. I was going to ask before for dysuria, but his main issue seems respiratory, but I guess it can
You
be
did have polyuria, so.
Yeah.
Yeah, I think it's reasonable. And Richard also said like ketones. I don't know if you're alluding to the UA, but sometimes like the UA, like you can see the presence of ketones as well. If you're looking for DKA, it's gonna come faster than like the serum ketones that you order. So it's definitely like not a bad idea. And again, if we're thinking there's a potential infectious etiology, like you said, like UTI, might not be a bad idea to rule it out as well. VBG definitely, like if you're concerned about DKA and some of the symptoms that may be related to potential acidemia, I think it's definitely reasonable. Though I would say like if you get to that point, definitely an ABG would be better than a VBG. But it's not unreasonable to start with that. And Omar specified that he would want it with lactates. Why with lactate, Omar?
It will also like assess like like if the patient was having an infection, because if he was having sepsis or septic, it will give us a better idea.
Okay, I think that's reasonable. Yeah, just wouldn't fall on the trap of just getting it with lactate, just because it's the easy choice.
Anyone
yeah,
concerned about profound anemia in someone with an esophageal cancer that could have been slowly bleeding is coming in tachycardic with exercise intolerance?
Definitely a possibility. Chronically ill, it seems like. I mean, he's had a past history of prostate cancer that was already treated, and now he has the esophageal cancer. So it's definitely a concern, I would add, to the CBC, and definitely would explain some of the presentation.
How would that explain the lung crackles? What was the JVD?
No JVD.
No JVD.
I guess that's why I also place BNP there. I don't know. I think it's like non-specific, but he does have.
Anemia, depending on the acuity, right? So especially like acute blood loss anemia will give you sort of a hyperdynamic circulation that puts you into heart failure. And that would give you those bibasilar crackles, but that should also give you a JVD. So it's a little hard to explain, but I like the thought of anemia, except that someone asked about melena and that seemed to have been ruled out. But it doesn't rule out a bleed, just because you haven't seen melena yet.
Okay. So I think we can go ahead and share some of the results, Rafa.
Yeah, sure. So the initial labs, his white count was 19. His hemoglobin was 8.2. His previous hemoglobin was 9 a month before. His platelets was normal. His creatinine was increased 1.9. His baseline is around 1. His sodium 133, mild hyponatremic. He was hyperkalemic 5.9. His bicarb was 13, anion gap of 22, glucose 571. He had ketones in the blood, beta hydroxybutyrate 5.6. His serum osmolality was high, 328. Viral panel negative, troponin negative, BNP 25, albumin 2.4. His VBG The pH was 7.34, PCO2 29, and his lactate was 3.8. In the UA, it was positive for glucose, ketones, and protein. Now we have the EKG. Anyone wanna try to read, or should I?
Yeah, and for the EKG, I would first like Dr. Ochoa, the fellow, when he gives the EKG workshop, I think one of the things that's important to keep in mind is who the patient is, who like the EKG belongs to, and why you got it as well, right? So in this case, after seeing like some of the labs and also knowing the presentation, what do we want to get out of this EKG?
Signs of hyperkalemia.
Okay, perfect. So potassium definitely high, at least on the value, so 5.9. And we're going to go back to the labs and dissect them a little bit more in the discussion. But definitely, at least from glossing over, you would want to make sure that you don't have signs of hyperkalemia, right? And what would those, which would those signs be on any case?
Peak T waves.
Exactly. So go back to the EKG, Rafa. Do you see like peak T waves here?
No.
Great. So that's at least a little bit reassuring. Not having that potassium 5.9, we don't see peak T waves. Another thing is like, I mean, in terms of the vitals, why would you have gotten it? Like we know the patient is tachycardic, right? And we're thinking the patient might have an infection, or the patient might have like, so I see Nadim is saying signs of heart failure, like LVH, sure. With a prolonged history of hypertension, that's something that you might be able to look at. And also, like, I mean, if you're thinking like potentially PE, or, we did have some slightly elevated lactate as well. Like, would you be thinking of any hypoperfusion or anything? Meaning, inverse T waves or something like that. It seems like I would say not in this case. In terms of the tachycardia, like characterizing it, many times with infection or like a strong, like a critical care patient that presents with sepsis, you might find like AFib. So like this patient's heart rate was elevated. It seems like it was regular, right? So here we see, what do we want to check? That it's sinus and that it's regular. So right now we have basically an EKG with sinus tachycardia, and that's kind of how you would go generally, like tying it to the patient. But of course, you always want to like review it in a structured manner as well. Okay. Rafa, if you could go to the next slide.
So, yeah, we have the chest X-ray. It was reported as new left lower lobe haziness that could represent pneumonia or atelectasis. Might have some nodules. I'm not sure in the lungs.
Okay. Yes, definitely. Well, we see that they reported the pneumonia. They said in the left lower lobe. Definitely, it seems like it's a situation where we would have benefited from a PA and a lateral. You cannot see, I would say, like all the potentially like the costophrenic angle on both sides, but after comparing it, it seems like maybe there's a little bit of an opacification there as well. So knowing this and knowing a little bit about the workup, how did your differential change?
I don't know, I can't remember if it was mentioned, the COVID was negative?
It was negative.
Okay, because to me, everything is COVID until the COVID is negative.
Yes, Rafa, do you remember if this case was COVID negative?
Yeah, it was negative. And influenza as well.
Yeah, and I think you had RSV as well, right?
Yes.
I'm not sure, But is there like some mediastinal widening there? Could that just be from like the esophageal? I'm not sure if there is, but I'm kind of seeing like a widened mediastinum there. And would that just be like from the esophageal carcinoma?
Yeah, I think it would be hard to say, especially like it doesn't seem like the best quality. It seems like even like you might have some lateral shift as well. So I don't think it's the best imaging to do that. It seems like in this case, you know, this patient, the mass was found on imaging and only a few months ago. So if you were concerned about anything with the malignancy, I would probably go back to those images and compare them with like the current imaging, right? That's normally what I would do instead of just trying to get it from an AP. Okay, so if you want to go back to the labs, or actually, let's just right now go ahead and we can start discussing a little bit more about the labs. Just give me 1 second. Okay, everyone can see my screen, right? So just going over the labs, I guess this patient has a lot of going on. So I wanted to take some time to actually go over like the information that we have. So let's start with the CBC. You know, what would you make of this white blood cell count?
It's high.
Definitely. And does that shock you? Is that something you expected? What else would you like? What would you think if this patient came in, you did the CBC and you get this result?
I think it is to be expected. All of us kind of agree he had some kind of infection, and we saw the X-ray, so leukocytosis makes sense.
Mm-hmm. And so we're going right now. What are you thinking in regards to the differential? Yes, Richard. I was going to say like it could also be stress-induced, possibly. I don't know if necessarily only with the vomiting, but exactly like if you take a look at the labs here, definitely you have some other conditions that could potentially cause it to be just a stress reaction. So what would you start thinking of? How would you distinguish the two?
We need to see the differential.
Exactly, miscellaneous. So many times, so I see many are saying neutrophils, like definitely sure. I mean, I guess a stress-induced response or neutrophilic could also like happen, but what specifically would shift you a little bit more towards an infection rather than a stress reaction?
Actually, so I had there was a case like a patient in the ED, and then I thought that it was neutrophilia or leukocytosis due to the patient being on steroids. And then for some reason on that patient, they reported a morphology of the white blood cells, but then I haven't seen that on anyone else. So I don't know if that's something that we can like order.
So many times when you get the CBC with differential, they'll report if there are like any bands, for example. So if you start seeing bands, that's an indication, or like the the left-sided shift, the so-called on the white blood cells. That would be something that would make you think a little bit more about infection as well, and would tie it a little bit more. And also, if your white count is very significantly elevated, if the white count was like 30, like with neutrophils instead of like 19, I would say that's something that would be a little bit more convincing about an infection. Normally with just stress reactions, you're not going to see numbers that high, right? So yes, definitely an infection is possible, but in this case, like you will probably see patients coming like this from the AD, because many times they get like CBCs without differential as opposed to us. So definitely I would want to follow up with the differential. Then in regards to the anemia that Dr. A had suspected, what do we make of it? Why do we think he has anemia?
He has cancer, so probably it could be from the malignancy.
Yes, so in this case, again, it's not entirely surprising. Sarah is making a good point. We need to know his baseline. Jonathan is saying chronic bleed versus sepsis, MCV, definitely. So those are all great points. So acute blood loss, I would say if you think it's from like the esophageal carcinoma, like, I mean, normally, or I would expect it to be present, like either, reported as hemoptysis or like some with his vomiting, or, some GI loss. Like I know it was asked about melena hematochezia, but definitely like it could be possible that he has chronic blood loss with his malignancy, right? Like maybe microscopic. And also definitely like I would want to differentiate that from anemia of chronic disease that everyone else mentioned. So definitely something where the MCV would help a little bit. Like it's probably going to be microcytic hypochromic if I had to guess, and then you would want to differentiate, like definitely get iron TIBC. Dr. A is saying also suspect. He is also right. Yes, that's another thing I was going to mention. So and it ties in a little bit to what Sarah was saying about his baseline. So this 8.2 might be hemoconcentrated at the moment. So if we remember his physical exam, he was already like with dry mucous membrane. So his actual hemoglobin level might be lower than it seems right now after fluid correction, and could definitely explain some of the symptoms of shortness of breath. So picking up the pace a little bit, like here we have an alkalos that's a little bit elevated, but if we're talking about potential DKA and also like, fluid status and lactic acidosis, it definitely reassures me a little bit that the liver enzymes are okay. Alkalos is slightly elevated. You can see that in malignancy. I would probably repeat it. And sorry, I have a little bit of trouble seeing here. So moving on to the BNP, what catches your eye here? And I would say just going in order, Rafa. So Nadim is saying low bicarb, good. So we have 13 here. But I would also say, Rafa, do we have a baseline creatinine? I don't recall hearing anything about CKD in the history, right?
Yeah, no CKD. His baseline was 1.
Okay, so baseline is 1. You have a creatinine of 1.9. And what do you want to check normally? So Jonathan is saying pre-renal AKI. Definitely something you can do, BUN creatinine ratio. In this case, even if you took like the BUN down to 40 and creatinine rounded up to 2, that's like your 20 right there. So it's something that could potentially be a mixture of like the fluid status with the anemia, right? So this patient is presenting with an AKI. What do we make of the sodium? The sodium is low. Why?
It's probably pseudo-hyponatremia in the setting of the hyperglycemia.
Excellent. So it's only like mildly elevated, and we see the hyperglycemia. Is there any other value that you can use to kind of like corroborate this finding? So if you have sodium, like hyponatremia, what's the first thing you order to kind of like start branching it into different buckets?
The osmolarity.
Yeah, exactly. And here in this case, it's high, right? 328. So you have hyperosmolar hyponatremia and you have hyperglycemia. So it is likely falsely lowered, and you have to correct it. In this case, I mean, there's different values of how you can correct it. Like for every 100 that you have of glucose above 100, you can add around 1.5. So in this case, it was, let's say, where was the glucose value? Sorry. So I see like 571. So you can say 400, about 400 above 100. So it's like 6. So if you correct it for that 6, it's like around 139 of the sodium like corrected, right? So it's not really like a true hyponatremia. What about the potassium? What do we make of that? Would you give this patient Lasix? Or how would you treat that? How, like, why is the potassium 5.9?
No, it's the same thing. Like
maybe
due to the insulin deficit, there's less potassium getting into the cell. So it's also like the total amount of potassium in the body may be the same, but still there's more potassium shift to the extracellular space.
Okay, yeah, great. So definitely would not start with like, I mean, we already have the EKG. You don't necessarily have to run and give like calcium gluconate, which is part of the management. Definitely wouldn't give Lasix if the patient is hypovolemic. So you mentioned about insulin deficiency. I mean, I think by now we can kind of like guess one of the most important diagnoses, right? Like what does this patient have? And how do you make that diagnosis? So Jonathan is saying HHS. Why HHS?
The osmolality is high and the glucose is really high. Like, so it's kind of just meets the definition of HHS, not DKA.
Yeah. So the glucose normally is like significantly higher, I would say, than 571. Normally it's even closer to 1000. If you went over like the typical presentation, definitely like the classic example of DKA would be type 1 diabetes in a younger patient that has complete insulin deficiency. Whereas like HHS is more like a partial deficiency of insulin. But with time, like your pancreas can stop like working, and then you can have a DKA presentation in like older patients. But I would put it in like a much simpler way. Like, what is DKA? If you take like each of those letters, like what does it stand for?
So the things I would suggest DKA would especially be his high anion gap, and also he's positive for the beta hydroxybutyrate. There's positivity for the ketones in the urine analysis as well. So putting this all together with the glucose levels that are high, but not that high compared to HHS, would mostly go to the site for DKA.
Yeah, exactly. So when making the diagnosis of DKA, I like to think of it like simply, you know, it's like DKA pretty much. Like you need hyperglycemia, you need ketones, and you need acidosis or acidemia. And in this case, like we see that like the patient has positive ketones, hyperglycemia, like we said, not as significant as you mentioned, to be like HHS. And also the patient is insulin dependent, has had type 2 diabetes for a long time. And we have also a possible stressor, right? We have leukocytes, we have pneumonia. So that's kind of how I would think of it. And just give me 1 second. And I think we've talked about most things, but one of the most important things as well is that the acidemia. So we have 7.34 of the pH. Well, we said ketones in the urine, like we mentioned, no UTI, glucosuria, and then we have a pH 7.34, so acidemia. What kind of acidosis would you say you have here? So we have a PCO2.
Metabolic acidosis.
Metabolic acidosis, why?
With a high anion gap.
Perfect. So PCO2, I think it was 29. Give me 1 second. Okay, so starting like just I guess I'll try to be brief because I know it's getting late. But just if you have like this acidosis, like how would you work it up? Someone already said the anion gap was elevated, but I guess before that, like you already have like this metabolic acidosis. What do you want to do first to confirm that this patient doesn't have any underlying respiratory pathology?
You could do Winter's formula, see if it's like an appropriate respiratory compensation, or if they have another mixed acid base as well.
Perfect. And do you remember the formula or no?
No, I would just MD calc.
Yeah, perfect. So you can do that. That one is actually not that complicated to do off the top of your head. So it's 1.5 times bicarb plus 8 and then plus minus 2. So in this case, we have the bicarb, so it's 13. I mean, you can bring it down to like or like, yeah, you can add like 6, let's say, like, so it's 19 like plus 8, then 27 plus minus 2, and then so you have 27 plus minus 2. This is 29. Definitely like fits. Like it seems like there is no underlying pathology on top of that, like respiratory wise, I think. So it seems like this patient is adequately respiratory compensating with respiratory wise. So I mean, in my mind, that would make it also like a little bit less likely the diagnosis of, you know, COPD or other things that we were expecting this patient to have secondary to his smoking history. And now, okay, now that we ruled out that this patient is unlikely to have any respiratory component on top of that, what would you want to do? So someone had already mentioned it before. I see Richard, or like the next mention, yes, you want to categorize it as anion gap metabolic acidosis. So I see here, did anyone actually calculate the anion gap, or did you go by what EPIC told you? And it is okay to go by what EPIC told you. You just need to know, I would say, how they got it. So how does EPIC calculate the anion gap for you? And I'm not talking about programming. I'm talking about the basic formula for anion gap. So Richard is saying, so that's the sodium minus the chloride and the bicarb. Perfect. So yes, that's a formula that you use. So I definitely like also use, like, it's easier to use EPIC. You just have to know, like, okay, like how they got it or which number you're using, right? And Jonathan is saying corrects for albumin. I don't think it does, actually. And that's why I'm saying that it's a little bit important to do it. So if you calculate what Richard was saying right now, so it's the sodium chloride and bicarb. So 133, 98, and 13, that gives you the 22. That's not even modifying for the albumin. So, and thank you, Jonathan, you actually did take me to the next step. So it is important to correct, like, for albumin as well, especially in a patient that is, you know, chronically ill with cancer. In this case, we have an albumin of 2.4. So you have many different ways of, sorry. Anyways, so you have many different ways of calculating there we go. Many different ways of calculating, like, how to compensate. Fastest way is definitely like, okay, sure, MD calc, but another thing you can do on the run is like 4 minus the albumin. It's like a quick and relatively approximate way to do it. So in this case, it would be 1.6. And if you add that to the anion gap, it would take you to like 23.6. And so yeah, definitely, I mean, you had an elevated anion gap even before this. But that just kind of like confirms that it's just something that you wanna be sure that you have before you start. And after you have the elevated anion gap, what is the next step that you want to do to confirm that this patient doesn't have any like non-anion gap acidosis or a metabolic alkalosis underlying? So delta, yes. And there's many ways to do it. Again, I'm just gonna go over kind of like the way I do it, because you have delta gaps, you have delta ratios, and it's a little bit inconsistent of how they interpret that as well. The way I like to do it is like using something called the bicarb before. And basically the way it does is you take the calculated anion gap and you subtract it to 12. So in this case, you're at, like, corrected anion gap, I said, was like about 23.5. So you subtract that to 12, and that's like that's how much, like 23.5 minus 12. So that's like 11 approximately. Like, I don't know, you add it to the bicarb. In this case, it would be like right here, you added like 11 to the bicarb. That's called the bicarb before, meaning you try to correct for the deficit of bicarb, or meaning like for every change in the anion gap, you have a 1-to-1 change in bicarb. So in this case, like before before the presence of the anion gap metabolic acidosis, you had a normal bicarb, meaning that this patient was unlikely to have any underlying disorder. And now we can say, I mean, like we said, we have the diagnosis of DKA and kind of trying to tie all these labs into the patient, right? I think it's a good thing to remember, like, why is this patient here? Like, what was the chief complaint? Shortness of breath. Exactly. And what do you find in the labs that explain that shortness of breath? And we kind of already glossed over like a few of them. I would say definitely, like we said, like the anemia, then you have the acidemia as well. And I would say in this case, I forgot to mention, but like what's the differential as well for anion gap acidosis? Now that we know we did all the workup and this patient has anion gap metabolic acidosis. Does anyone remember any mnemonic?
Mud piles is the first aid.
So mud piles, yes. So mud piles is one, gold mark is another. But basically, so mud piles is what, Omar? You want to share?
So methanol, uremia, DKA, propylene glycol, isoniazid or iron, lactic acidosis, ethanol, glycol, and salicylates.
So sorry, we're breaking up a little bit, but yeah, it's methanol, uremia, DKA, you have iron isoniazid, and lactic acidosis were one of those as well. But also with gold mark, you have like the glycols, you have aspirin. So these are some of the things that you want to be thinking. In this case, this patient has a little bit of lactic acidosis and DKA, right? And basically how, like, after like looking at all the labs, we said like potassium, you would treat it probably with insulin, not act on it. Hyponatremia is probably not real after you correct from it. Definitely like the glucose and like the physical exam told you that this patient is significantly volume depleted. So you would probably start giving this patient fluids, right? And if you're worried about infection and pneumonia, maybe like some antibiotics as well, treat the source. It's a potential trigger for DKA. And for dispo, where do you think this patient is going to go? ICU? Yeah, if the patient requires insulin drip, that is something that needs to be done in the ICU because you need a finger stick every hour and you need a lot more care. So definitely that's where the dispo would end up being. But yeah, I just wanted to like kind of go over how like we would interpret the labs in a patient like that. Raj says it's more likely that the patient stays in the AD until the gap closes. Pending bed availability, that might be closer to the truth. But yeah, sometimes like there are some very like specific criteria where you can actually close the gap in the unit with sub-Q insulin. But Raph is actually going to tell us a little bit more about the full management of DKA. If you want to just share your screen, Rafa.
Yes, sure. So we've just talking about DKA now. It is a disease of insulin deficiency with high levels of glucagon and cortisol. There is a triad of hyperglycemia, high anion gap, metabolic acidosis, and ketones in the blood. The hyperglycemia, it is usually around 350s to 500. The patient usually is having polyuria, polydipsia, weight loss, nausea, vomiting, abdominal pain. We also usually find some other labs abnormalities as in this patient, pseudo-hyponatremia. As Rafa already said, usually the sodium decreased by 2 for each 100 of glucose concentration increasement. And also with the potassium usually is abnormal because of the total body deficit of potassium due to urinary loss. In DKA, we usually have precipitating events. Most common is pneumonia or UTI, also discontinuation of insulin therapy, dehydration, major illness like pancreatitis or sepsis, or other new medications as steroids, dobutamine. The management of DKA consists of volume, IV fluids, potassium, and insulin. The goal is to treat the underlying condition, to give IV fluids, correct anion gap metabolic acidosis and hyperglycemia, and replete electrolytes. So the first one for fluids, usually we give 1 to 1.5 liters of saline over the first hour. Then we start to 250 to 500 cc's per hour of saline. And when the glucose is between 200 to 250s, we switch fluids to D5, half saline, at 150 to 250 cc's per hour to prevent hypoglycemia. The other factor that we need to take care is the potassium. The goal is to keep the potassium between 4 and 5. When we start the insulin, the potassium will decrease because of the intracellular shift. If the potassium is lower than 3.3, we don't give insulin. We only give fluids and start repleting potassium in the fluids until potassium is greater than 3.3. And we need to check the lab every 1 to 2 hours. If the potassium is between 3.3 to 5.3, we can start giving insulin, but we also give fluids and we replete potassium in the fluids as well. If the potassium is greater than 5.3, we don't need to give potassium. We just give insulin and fluids. Regarding the insulin, we only give insulin when the potassium is above 3.3. We start IV insulin bolus 0.1 units per kilogram. Then we start the drip at 0.1 units per kilogram per hour. Our goal is to decrease the glucose by 50 to 75 per hour. And we are checking finger stick every hour to adjust the drip rate. When the glucose is between 200 to 250, we decrease the insulin drip rate to 0.02 to 0.05 units per kilo per hour. But when should we stop the insulin drip? When the anion gap is closed. Our lab, it shows that normal anion gap is below 16. When the bicarb is above 18, glucose below 200, and the patient is stable and ready to eat. If the patient is already eating, we can give the long-acting insulin, sub-Q, and then we just stop the insulin 2 hours after giving the long-acting insulin. We will monitor the patient, monitor the vitals, mental status, and urinary output. We'll do finger stick every 1 hour. We need to do baseline labs, then after 2 hours, and then after 4 hours. We usually do electrolytes, BUN, creatinine, and VBG, and the patient is usually NPO while on the insulin drip. So just quickly back into our case, 67-year-old male with type 2 diabetes presenting with DKA in the setting of pneumonia, poor PO intake, and not using his insulin. We started antibiotics for his pneumonia. His glucose was 500, his anion gap 22 when he first came in. We started insulin drip. We monitor his finger sticks every 1 hour. So at 4 p.m. when he came in, we started fluids, 1 liter bolus, started insulin drip, and we didn't give any potassium because it was 5.9. We can see that the glucose slowly went down. At 1 p.m., his glucose was below 200. The insulin drip was decreased to 0.05. He was able to eat, so we gave lentils, and we switched the fluids to D5 half saline to avoid hypoglycemia. And eventually, after 2 hours, we stopped the insulin drip. This is just a protocol from UpToDate that summarizes everything that we just talked. I will not go through everything. And just some take-home points. During DKA, usually we have precipitating events. We need to treat the underlying cause as infection or not using insulin. The treatment consists of IV fluids, insulin, and electrolyte replacement. We don't give insulin unless potassium above 3.3, and we only stop the insulin drip 2 hours after giving the long-acting insulin sub-Q. And this is just a wellness script that we just discussed, just to summarize everything, and that's pretty much it.
Thank you so much, Raphael. That was a great case and great summary of DKA at the end. Anyone have any questions or comments?
Do we know what happened to him besides his DKA?
Eventually, he died in the ICU. His AKI continuously to worsening, and we found out that he had some mets in the lungs. He became DNR, DNI, and comfort care, and after 8 days, he passed away in the ICU.
Great, thank you. So clearly, he was a lot more sick than anybody knew.
Yeah, and I guess you could also tell from the antibiotic choice, cefepime, vanc, and etc. They left that to completion. Definitely, like, thought that the patient was not improving in the ICU, I would say.
You know, that's why I think, it was important to get more information on the past medical history. And actually I was surprised with the choice of antibiotics to be so, broad coverage without really focusing more on aspiration, which, you know, with esophageal cancer, I would fear that. I was also surprised with the chest X-ray that the report was only the left base as being abnormal. To me, it looked like both bases were abnormal. I mean, the bases look very different, right, from the upper half of the lung fields. So I'm not sure. I didn't see any, you know, bronchogram, but it just looked, you know, very busy bases. So that made me curious about, you know, the status of those lungs, particularly interstitial, because he did have rails and they were bilateral, not just left. So, you know, I was curious about all that.